Thank you for inviting me to speak at this webinar of the Wilson Disease Association. I have no relevant conflicts of interest to disclose. You can see that this talk is coming from Nova Scotia, and indeed it was prepared in rural Lunenburg County. We are located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq. If you have any questions about this talk, please send them in as soon as you can so that they can figure into the question and answer period following the lecture. So, what's in a word? Is this lecture about compliance or adherence? And does it matter? Some people view these two words as equivalent and interchangeable. I don't see it that way. With respect to medical treatment, compliance is the older term, and adherence is the newer term currently preferred. I can't find any technical difference between the two words, although at one time I thought there was a technical difference. What has become apparent is that the critical factor here is the doctor-patient relationship. When you talk about complying, the power is really on the side of the doctor. You are complying with the doctor's request. However, when we talk about adhering, then the focus is on the patient who agrees to a medical treatment and also agrees to having it customized to your own needs. So I will argue in this lecture that adherence in Wilson disease involves a collaborative approach between doctor and patient so that the power split is approximately 60% to the patient and 40% to the doctor, and thus the patient is empowered. So it's reasonable to ask whether this attention to adherence in Wilson disease is new. After all, we have always emphasized the importance of taking medication for Wilson disease consistently. So it's not really a new or emerging topic. However, I would point out that the usual approach to adherence is something on the order of take your medication or else. What is new and emerging, I think, is the way we look at adherence. We're now beginning to examine it objectively by questionnaire or by studies of relevant biochemistries. We're recognizing reasons apart from non-adherence for treatment failure, and we're looking for effective and positive interventions to support adherence. Furthermore, and these are in green print because they're perhaps a bit more innovative, we are shifting the responsibility from the patient to shared with the healthcare providers. And we are trying to take a practical and realistic approach to promoting and ensuring adherence. My second key point for this lecture is that an organization like the Wilson Disease Association can gather and provide information about problems with adherence in Wilson disease and also practical ways of coping. After all, no matter how sympathetic a physician may be, we do not have the same real-life experience as somebody who actually has Wilson disease. So what am I talking about? When I say adherence to a medical regimen, I mean running your life in such a way that is regular and consistent and appropriate for managing your disease. And usually this features taking the prescribed medication as directed and without fail, and observing dietary and other possible restrictions. There are also aspects of adherence which I think are not adequately emphasized. For example, seeking and getting accommodations that you may require, and that could include psychological supports, and also paying attention to lifestyle issues which should be important whether or not you have Wilson disease, such as maintaining a healthy body weight, getting enough exercise, avoiding alcohol, and making sure that you get protective immunizations against other diseases. So it's not just taking your meds every day. And I think this is a description of adherence which could apply to other diseases such as type 1 diabetes, cystic fibrosis, and other rare genetic diseases, and liver transplant. And I mention that because the research done with those diseases can be broadly relevant to Wilson disease. I've been interested in this problem for some time. In 2016, when we were designing clinical and translational perspectives on Wilson disease, we included a chapter on transition and adherence. From a pediatric point of view, the movement of patients from the pediatric clinic to the adult clinic was very important, and adherence was a big feature of that move. So we knew it was an important topic. We also knew there wasn't much to be said about it. So we encouraged our expert authors to draw on their experience with liver transplantation. And I think this experience has one additional take-home message, and that is that life is full of transitions, and these may be times of vulnerability in terms of achieving or maintaining adherence to a medical regimen. There is some research on this topic in Wilson disease. Papers from the French group led by France Voimont are important. And this one is their 2021 paper, a cross-sectional study of about 130 adults, all of whom had Wilson disease and had been treated for at least 1 year. These patients were living independently and they were capable of making their own decisions. There were no liver transplantations in this group, and there were no very severely affected neurological Wilson disease patients. That's important because this group is populated mainly by neurologists. They use the Morisky medication adherence scale in a validated French version to examine adherence, and their study was balanced in terms of gender. Their findings were that only about 20% could show high adherence on this scale. About half of the patients had medium adherence, and about a third had poor adherence. So to qualify as high, you had to get 100%. To qualify as low, you could only say yes to 5 or less questions out of 8. They found that adherence was better with the neurologic form and poorer with asymptomatic Wilson disease. They also found, perhaps surprisingly, that having somebody else affected in the family or having a higher level of education, or which was actually the drug in your treatment regimen, did not influence adherence. They did find that patients who were having problem with delivery or storage of medication tended to be non-adherent. And they also found that non-adherent patients had evidence of less satisfactory disease control, namely high serum ALT and high serum exchangeable copper. So here is the French version of this scale. And all I want you to notice is that they modified it so that recall was over the previous month in most of the questions, unless it's specified 2 weeks ago or yesterday. Here's the Morisky test questions in English taken from the web. And I've blocked out the high blood pressure pills allusion because this was actually developed for patients with hypertension. And you can see the kinds of questions they are asking. Do you sometimes forget to take your pills? Are there any days when you didn't take them? Do you sometimes cut back and not tell your doctor? And so on. You can read these. If we try to make this more suitable for Wilson disease, you can see some problems. Did you take your pills? Well, both doses, all 3 doses? Did you miss 1 dose? Did you miss 2 doses in a single day? Have you ever cut back or stopped your medication without telling your doctor? But it could not be limited to because you felt worse when you take the medication. There could be lots of other reasons. Number 5 is clearly an internal validation question. Number 6, do you sometimes stop taking your medications when you think everything is really good? That certainly relates to asymptomatic Wilson disease. And is taking a medication an inconvenience? Do you feel hassled? So is this an allusion to bullying? Is it a question of time management? These are good questions to be asking. So going back to what they found, I must admit it would be hard, I think, for all of us to get 100% on that set of questions. Medium adherence seems more like what most of us would qualify as. So what's really important here? I think what's really important is that 1/3 of these patients couldn't even manage medium adherence. Another recent paper is from the Warsaw group, and is a little bit older, and they actually don't look at adherence. They look at persistence. Now, non-persistence in taking in a medical regimen is really the extreme limit, the extreme version of non-adherence. And these authors defined it as at least 1 reported break, where a break is not taking any medication at all, of more than 3 months, or a minimum of 2 breaks lasting longer than 2 months. I think that means each of them was at least 2 months. They had over 200 patients. They studied them over a 10-year interval. And in the end, they had 170 subjects to analyze. They were all adults. And what they found was that there was really quite a high rate of persistence, 74%. And they could see that patients who were persistent, who took their medication without breaks, had a good treatment outcome. So here, I think the really important take-home message is 1/4 of these patients did not qualify as persistent. They were non-persistent. So, and these patients did not do as well. So this study really gives us some numbers about the general contention that we tell our patients with Wilson disease that consistent lifelong treatment is important. And indeed, a previous study from the same group showed that effective treatment of asymptomatic Wilson disease prevents overt symptoms from developing. Okay, let's look at this problem from another point of view. And it is simply this: your Wilson disease treatment was working, but now it is not working. So the usual way for us to detect not working is in the blood work, increased serum aminotransferases, the liver function tests. Although it could be the onset of a new tremor or some other symptom which seems just not quite right. And indeed, non-adherence is usually the likely explanation. However, in the 2022 AASLD practice guidance on Wilson disease, this issue was approached as an instance of treatment failure, and the point was made that there are various possible causes. Non-adherence may be at the top of your list, but there's a list. And that list can include drug failure. In other words, you're taking the medication properly and faithfully, but the medication itself has stopped working. It could be an acute liver problem unrelated to Wilson disease, such as getting hepatitis A when you're on vacation in the tropics. Or it could be some other liver problem that's developed. It could be misadventure, by which I mean you're adherent, but you're not taking the medication properly. It could reflect social issues, such as you're adherent, but you're rationing the medication because it's too expensive. Or it could indeed be non-persistent. You've put yourself on a drug holiday for some reason. And the point is that apparent treatment failure requires objective investigation, not a simple leap to the diagnosis of non-adherence. So let's just talk a bit more about misadventure and social issues, since these may be new features of the discussion. And a good example of misadventure is with zinc, when you're taking it with food or at mealtime because you want to avoid having an upset stomach. Not everybody has that problem, but some people do. Taking medications once a day instead of spreading your medications out into 2 or 3 doses. And then the problem of hidden copper in your diet. So you don't mean to be taking a high copper diet, but you may not realize that your health food supplement has a lot of copper in it, or something like that. Social issues, we get back to the matter of rationing expensive drugs, or indeed drug supply issues, such as a climate calamity, as we've seen, hurricane, tornado, an earthquake, floods, political unrest, pharmacies being closed down, or indeed factories being shut down. So my suggestion is that adherence requires active planning. And these would be some of the steps that I think we need to consider very specifically. First of all, you need to recognize the challenge of really good adherence. And then you need to identify your strengths and your weaknesses in terms of meeting that challenge. Then you can plan accordingly, and you can actually be prepared to be flexible. And finally, and possibly most important, you should plan to succeed and should get off to a good start. The Polish paper emphasizes that a supportive family environment is important. And the French paper argues strongly that a multidisciplinary team providing health care for people with Wilson disease is important. So the basic challenge here is lifelong treatment. And really, we want each Wilson disease patient to achieve the good outcomes associated with what I have called the treated natural history. I talked about that at a previous webinar, and you will recall that when a patient with Wilson disease is identified early, treated effectively, and remains adherent, you can expect to approximate to the survival curve of normal people in your country. We see this in the Czech Republic, in the graph here. The Polish group reports the same thing. The Austrian group thought it wasn't quite as good as general survival, but pretty good. And of course, there can be some complications along the way. So in other words, lifelong treatment equals long life treatment. I realize that's a kind of silly way of putting it, but honestly, it reflects what I think about when I start a patient on treatment for Wilson disease. It's not a marathon. Sorry, it's a marathon and it's not a sprint. And there are things we can do to promote adherence. We can recognize, first of all, the challenge of being 100% adherent for your entire life. We can spell out the need to continue taking medication even when you feel completely well. And we can anticipate the dicey but normal situations that are going to develop. Ideally, specialists in Wilson disease ought to be able to provide team support or other mechanisms to encourage adherence. And that includes such things as social media reminders, maybe an app that reminds you to take your medication, a pharmacy prescription renewal plan, and pill boxes. Very simple solution. We need to be clear about what is expected and what is the right way to take medication. And that communication has to go to patients, the family, and caregivers. And we certainly need to keep communication lines open and generate an environment of positive attitudes. And of course, monitoring is one of the things that is absolutely requisite indefinitely. What can a Wilson disease patient do? Well, I think apart from hoping that the environment for adherence is well established, it's important to let your doctor know when things aren't going so well. And although there's very little evidence to suggest that understanding your treatment is really significantly important, I do think it's important that you understand the what and the why of treatment for Wilson disease. What can the Wilson Disease Association do? I see it as a clearinghouse for strategies to achieve good adherence. For example, this is what works for me. I have little pill boxes that give my once-a-day pills in the week. I set it up for 2 weeks in advance, and then I can keep track of my own adherence to my medications. Perhaps we should be developing a self-test for adherence in Wilson disease. We could use the Meriski questionnaire as a guide, and we would customize it to the special needs of Wilson disease treatment. And certainly the WDA can encourage research on adherence in Wilson disease. And what about the drug research itself? We're looking for treatments that work, that people will actually take. That's what effective treatment really is. We can increase basic pharmacological research to find different kinds of drugs or therapies. We can use clinical pharmacology to find drugs that are easier to take. For example, once daily dosing, the new triantine tetrahydrochloride, which is stable at room temperature, doesn't need refrigeration, may be good for some people. We can initiate research to optimize treatment modifications at different times of life. For example, pregnancy, or when you are stable and on maintenance therapy. This, in my view, is old-fashioned personalized medicine. And I don't want you to confuse it with the contemporary treatments that take into account the mutations of the ATP7B gene. We might talk about that sometime in the future. This is much more fundamental. And with that, I will thank you for your attention, and I'd be happy to welcome any questions.
Well, hello to those of you who are attending this webinar around the continent and possibly around the globe. I'm now talking to you from Halifax, Nova Scotia. And there are several questions which have come in. I will start looking at those immediately and talking about them. The first one has to do with standards of care. Do I have an opinion about those? And what about the need for a new chelating agent? Well, I would say that the current standards of care represent an evolution of practice since the early 50s. And of course, they are still open to further evolution, but those that we have right now are in good standing, as it were. They seem to me to be reasonable standards of care. Do we need a new chelating agent? Thank you for asking that question, because I've asked myself that question in the past. My original reaction was no, we have great medications to treat this disease and good outcomes. But the fact is, some people do not respond to some of these drugs that we already have, or they experience toxicities from those drugs. And so if we're really going to personalize treatment for Wilson disease, we need to have as many options as possible. So thus, I do think we need new chelating agents, not just one. What are the key endpoints? Well, one of the key endpoints, in my view, is being clinically well, being a person who can get on with life, with doing what you want to do, and being happy and healthy in doing so. The other endpoints, I believe Dr. Shilsky will talk about further, which has to do with meeting the kind of biochemical parameters that we think are the signals that treatment is effective. Somebody else has asked about a smartphone app to support Wilson disease medication adherence. I don't think they exist. I think there are some really good examples from other diseases, and specifically from the liver transplant experience, which could help us to design the appropriate smartphone app or apps. Many pharmacies nowadays do have the ability to track your prescriptions and make refills available and alert you to the fact that they're ready to be picked up on an app. So it could be that we need more than one kind of app for Wilson disease, and some of those are already available if you can take advantage of them. Now, there's also a school of thought, and right now I still see this as a way to proceed. I like to order my own refills, fill my own pill boxes, and know what I'm taking. And I do sometimes worry that if it becomes too automatic, and there's an app for that, that you may lose a bit of the sense of understanding and control of your medical regimen. I don't know about apps for talking to your primary caregiver. This is pretty much and something which primary caregivers might want to start. And it might be that for certain diseases where supervision should be fairly close, and Wilson disease could be an example of that, that it would be worthwhile to have some interest or agitation to get primary care docs or family doctors having some kind of app to help coordinate care. I'm sure that there would be regulatory questions and questions from the College of Family Physicians that would have to be met for that kind of service. But I agree with this person who's posed this question that it would help monitor medical adherence, and it might be particularly valuable at transition times when your Wilson disease patient is moving to a different home or changing jobs or going off to university, and you'd like to have a little extra supervision remotely. Okay, what is multidisciplinary team-based adherence? Well, apart from being a mouthful, this is the idea that a disease like Wilson disease is managed by a team of specialists with different kinds of expertise. So such a team might consist of a hepatologist, a neurologist, possibly a psychiatrist, perhaps a physical therapist, maybe a speech therapist, a nutrition, a dietitian. And in my worldview of this, we would create the team from a number of different possibilities to suit the needs of a patient. Clearly, if you have asymptomatic Wilson disease and are totally well, you don't need to worry about problems with your handwriting or needing physiotherapy or possibly occupational therapy, whereas other patients might. So this is the idea that we deal with this disease by having a team, and the team is effective and focused enough that it promotes adherence to the entire medical regimen, taking your pills, watching your diet, and then doing the other things that maintain generally good health. Somebody else, or perhaps the same person, wants to know about with a drug like Triantine, which we take twice a day, does it have to be 12 hours apart? I have always thought that you did have a little bit of leeway there. And so for my patients, I would certainly not expect them to set an alarm and take the pills exactly 12 hours apart. First thing in the morning, last thing at night is a reasonable regimen, as long as you're going to bed relatively late, like, you know, getting up at 7 and going to bed at 10, or so we're not stretching the closeness too much. Also, these are times when you can take it easily on an empty stomach, and I think that's important. Another thing which I've personally found helpful is when I need to do something regularly, if I kind of latch it onto something I really do regularly, then I'm more likely to do both of them. So for example, I could brush my teeth on the way to bed, and then I could stop in the kitchen and take my medication at that time, because I always go to bed. I always brush my teeth, and then I can easily bundle in taking my medication last thing at night. I hope the kind of practical example is of some help to you.
Okay, I'm sorry, but we are out of time. We need to move on to the next presentation.
That's great. Thank you very much, and thank you for letting me participate in this webinar.